There is a man in your life right now, maybe your father, maybe your grandfather, maybe you yourself, who is getting up 3, 4, 5 times every night to urinate, who plans every outing around bathroom proximity, who has quietly accepted that sleep is something that happens to other people, who has been told that his options are either medication that gives partial relief with its own side effects, or major surgery that involves blades and recovery time and risks he finds genuinely frightening. What very few people in that situation have ever been told is that a third option exists. A minimally invasive procedure performed through a tiny entry point in the wrist or the upper thigh while the patient is awake takes roughly an hour, requires no cutting and no general anesthesia, and has the patient home the same day. A procedure backed by multiple randomized controlled trials showing outcomes comparable to the traditional gold standard surgery for prostate enlargement. I am Dr. John, and today I want to walk you through everything you need to know about prostate artery embolization, what it is, how it works, who it is right for, what the results look like, and what the honest risks and limitations are. Because informed patients make better decisions, and most men managing enlarged prostate symptoms have never been given access to this part of the conversation. Before we begin, leave a comment with your age and how significantly your prostate symptoms are currently affecting your quality of life. I read every single comment, and the answers genuinely shape what I prioritize in future conversations. Let me start with the problem itself, because understanding the underlying anatomy and how BPH produces its symptoms is the foundation for understanding why the treatment works the way it does. Your prostate is a small gland, roughly the size of a walnut in a healthy adult male, positioned at the base of the bladder. Running directly through its center is the urethra, the tube that carries urine from the bladder through the penis and out of the body. This anatomical relationship is everything when it comes to understanding BPH. As men age, typically beginning somewhere in the 40s and accelerating through the 50s, 60s, and beyond, hormonal changes create conditions that cause the prostate to enlarge. Rising dihydrotestosterone, a more potent metabolite of testosterone produced through the action of an enzyme called 5-alpha reductase, promotes prostate cell proliferation. Simultaneously, as testosterone declines with age, estrogen levels in men rise relative to that declining testosterone, and estrogen further stimulates prostate tissue growth. The result is gradual, progressive enlargement that compresses the urethral channel running through the center of the gland. That compression produces the symptoms that affect as many as 60% of men over 60 years of age and approaching 90% of men over 80. When the urethral channel narrows, urine has to push through a tighter passage with each void. The stream becomes weaker and thinner. Getting the flow started requires effort and sometimes prolonged waiting. The stream may stop and start rather than flowing continuously, and even after urination feels complete, significant residual urine often remains in the bladder because the bladder could not generate enough pressure to overcome the obstruction and empty fully. That residual urine fills back up relatively quickly, producing the cycle of frequent trips to the bathroom that characterizes advanced BPH. At night, when the body's natural antidiuretic hormone slows kidney filtration during sleep, the effect should be fewer bathroom trips. But when the bladder is already starting from a state of partial fullness rather than genuine emptiness, it reaches capacity more rapidly, producing the nighttime awakenings, sometimes 2, 3, 4, or even more times per night, that disrupt sleep so profoundly. Chronic sleep fragmentation from nocturia is not merely inconvenient. It drives elevated cortisol, worsens insulin resistance, accelerates inflammation, reduces testosterone, and compounds the very hormonal imbalances driving further prostate growth. It is a cycle that compounds itself. When symptoms are mild to moderate and caught relatively early, several approaches are available. Alpha blocker medications relax the smooth muscle of the bladder neck and prostate, opening the urethral channel mechanically without reducing the gland size. Symptom improvement typically begins within days, but the underlying enlargement continues. 5-alpha reductase inhibitors like finasteride and dutasteride take a different approach, blocking the enzyme that converts testosterone to DHT and over time producing modest actual shrinkage of the prostate. These are most effective in men with larger glands, but they take 6 months to a year to produce meaningful size reduction and carry sexual side effects that many men find unacceptable. Lifestyle modifications, dietary changes, strategic fluid timing, regular physical activity, and weight management address the metabolic drivers of prostate growth and can meaningfully slow progression, but they are rarely sufficient alone in moderate to severe disease. When symptoms progress to the point that medications and lifestyle changes no longer provide adequate quality of life, or when complications develop such as urinary retention, bladder stones, or kidney involvement from chronically elevated pressures, more definitive intervention becomes necessary. The traditional gold standard surgical intervention is called TURP, transurethral resection of the prostate. A urologist passes an instrument called a resectoscope through the urethra, uses the camera to visualize where the prostate is obstructing the urinary channel, and systematically chips away the obstructing tissue to widen the passageway. TURP has decades of proven efficacy data behind it and remains one of the most reliable treatments available. However, it requires general or spinal anesthesia, typically involves a hospital stay of 1 to several days, requires a recovery period before normal activity can resume, and carries risks including bleeding, infection, and retrograde ejaculation, in which semen is redirected into the bladder rather than expelled normally during orgasm. This is the context in which prostate artery embolization, commonly abbreviated as PAE, has emerged as a genuinely compelling alternative for many patients. Let me explain the procedure in terms that make the mechanism completely clear, because I want you to understand exactly what is happening inside the body when this works. The prostate, like every other tissue in the body, depends on its blood supply for survival and growth. The arteries supplying the prostate with oxygen and nutrients are the prostatic arteries, small vessels branching from the larger internal iliac arteries in the pelvis. The prostate tissue that is hypertrophied, that is enlarged and is causing the obstructive symptoms, is maintained by this blood supply. Reduce or interrupt that blood supply to the enlarged tissue, and that tissue undergoes ischemia, essentially starving for oxygen and nutrients, and begins to shrink. This is precisely the mechanism that prostate artery embolization exploits. The procedure is performed by an interventional radiologist, a physician who specializes in image-guided, minimally invasive treatments performed through blood vessels rather than through surgical incisions. The patient arrives, is prepared, and receives local anesthesia only at the access site, which is either the radial artery at the wrist or the femoral artery at the upper thigh. A tiny wire thinner than a millimeter is introduced through this access point and navigated through the arterial system under continuous imaging guidance, moving progressively through the larger vessels toward the smaller prostatic arteries specifically. The catheter used for the final navigation is extraordinarily fine, sometimes as small as 0.4 millimeters in diameter, allowing access to the specific small arteries feeding the prostate while minimizing any impact on surrounding structures. An angiogram, essentially a real-time X-ray showing the contrast material flowing through the vessels, is performed to confirm precise positioning and map the blood supply to the prostate. Once correctly positioned, embolic agents are injected through the catheter into the prostatic arteries. These agents are either microscopic particles designed to lodge in and block the small vessels, or in some cases, a medical-grade liquid adhesive that permanently occludes the targeted vessels. The blood supply to the enlarged prostate tissue is cut off. Even when the procedure is highly successful, it is rarely possible to stop 100% of the prostate's blood supply, and some collateral circulation typically restores partial flow over time. However, a significant portion of the most enlarged tissue undergoes ischemic necrosis, dies, and is reabsorbed by the body, and the gland shrinks. This shrinkage opens the urethral channel. The obstructive symptoms improve. Urine flows more freely with better force, more complete emptying, and far fewer nighttime awakenings. Once the embolic agents have been delivered and the angiographic check confirms appropriate treatment, all of the wire and catheter hardware is removed entirely from the body. A small radial band is placed over the wrist entry point or a simple compressive dressing over the thigh entry point. No incisions, no sutures, no scar, and no hospitalization. Most patients are discharged within 2 to 3 hours of the procedure completing. The recovery experience is markedly different from surgery. Most men can resume professional work the following day. Physical activity restrictions are minimal. The primary post-procedure experience is what is called post-embolization syndrome, a temporary period of low-grade flu-like symptoms, including mild fever, fatigue, and localized discomfort, as the body responds to the ischemic changes in the prostate. This typically lasts a few days to a week and is managed with standard anti-inflammatory medications. Now let us address the evidence honestly, because PAE is not a perfect procedure and deserves to be understood with both its genuine strengths and its real limitations clearly presented. The clinical trial evidence supporting PAE has grown substantially over the past decade. There are now at minimum 7, and by more recent counts approaching 9 or more, randomized controlled trials directly comparing PAE outcomes to conventional surgical approaches, including TURP. The consistent finding across these trials is that PAE produces symptom relief, measured by validated scoring systems like the International Prostate Symptom Score, that is genuinely comparable to surgery at 12 months, 2 years, and in some trial extensions beyond. Patient satisfaction rates in these trials are high. Quality of life measures improve significantly. Urinary flow rates improve. Post-void residual volumes decrease. These are objective, measurable outcomes, not simply patient impressions. The primary limitation that the evidence consistently identifies is a higher recurrence rate over longer time horizons compared to TURP. At 5 years post-procedure, TURP recurrence rates are typically in the range of 5 to 8%, meaning 5 to 8% of patients require additional treatment within 5 years. PAE recurrence rates at 5 years are typically in the range of 12 to 17%. This is a meaningful difference and deserves to be part of every informed consent conversation about this procedure. However, the practical implication of this higher recurrence rate requires some nuance. 83% of patients at 5 years from a minimally invasive, outpatient, locally anesthetized procedure still have adequate symptom control without requiring additional treatment. For men who do experience recurrence, the procedure can generally be repeated since it leaves the anatomy intact and accessible. And for men who prefer to avoid the risks and recovery of surgery, particularly those who are older, have higher surgical risk due to other medical conditions, wish to preserve ejaculatory function, or simply prefer a less invasive approach, PAE offers a genuinely compelling trade-off. Let me address the success and safety statistics candidly. Technical success rates of PAE, meaning the physician was able to successfully navigate to the prostatic arteries and deliver the embolic agents as intended, are approximately 99% in experienced hands. In approximately 1% of cases, the arterial anatomy is unusually complex, or the positioning of the prostatic arteries relative to adjacent structures creates a risk of unintended embolization of nearby structures, and in these cases, the responsible decision is to abort the procedure and recommend surgery instead. Clinical success rates, meaning patients who experience meaningful improvement in their symptoms, are approximately 90 to 92% in experienced centers. This is consistent with what well-performing surgical centers achieve. The primary serious complication specific to PAE is called non-target embolization. This occurs when embolic particles or agent travel into vessels other than the intended prostatic arteries, potentially reaching adjacent structures. The most commonly discussed manifestation of non-target embolization is a penile ulcer resulting from interrupted blood supply to the penis. This is genuinely a concerning complication, and experienced operators take multiple technical precautions specifically to prevent it. The rate of significant non-target embolization in experienced centers is low, and most cases that do occur, including penile ulcers, resolve with conservative management over weeks without permanent damage. However, this risk is real and is a critical part of the informed consent conversation. Who is PAE best suited for? Men with moderate to severe BPH symptoms who have not responded adequately to medical management, or who prefer to avoid long-term medication. Men who are at elevated surgical risk due to age, cardiac conditions, anticoagulant use, or other medical factors that increase the risk of anesthesia and conventional surgery. Men who specifically wish to preserve ejaculatory function, since TURP and most surgical approaches carry significant rates of retrograde ejaculation, while PAE rates are substantially lower. Men with very large glands, sometimes over 100 or even 200 cubic centimeters, where conventional surgical approaches become more technically demanding and carry higher bleeding risk, while PAE can be highly effective. And men who simply prefer a same-day, minimally invasive approach and accept the trade-off of potentially higher long-term recurrence in exchange for avoiding the risks and recovery of surgery. PAE may be less appropriate for men with certain arterial anatomies that make safe navigation technically impossible. Men with significant kidney function impairment, since the contrast dye used in the procedure affects the kidneys, or men with specific contraindications to the procedure that an interventional radiologist would assess during the initial consultation. What do I want you to take from today? The most important thing is this: if you or someone you care about is managing prostate enlargement symptoms and has been told the only meaningful options are medication or surgery, that information is incomplete. A third category of treatment exists, and it is supported by robust randomized trial evidence, offers genuine symptom relief with a favorable safety profile in experienced hands, and can be delivered in a daycare setting with minimal recovery. Accessing this treatment means specifically seeking a consultation with an interventional radiologist who performs PAE, in addition to the urological care you may already be receiving. Both specialties have expertise relevant to BPH. Both have legitimate and complementary roles. Understanding both treatment pathways, their respective evidence, advantages, and limitations, is what positions you to make a genuinely informed decision rather than simply accepting the first option recommended. The symptoms of BPH do not have to control the quality of your life. The disrupted sleep, the constant planning around bathroom access, the weak stream, the frustrating incomplete emptying, each of these has a solution, and now you have a more complete picture of what those solutions actually are. This is Dr. John. Your health decisions deserve complete information. I will see you in the next one.